about the stuff in the briefing box. Hepatic encephalopathy. What goes through your mind if I tell you hepatic encephalopathy? Yes, Anna?
The liver doesn't work properly, so it can't detoxify the blood. So you become confused.
Yeah.
All of that.
You have signs that
Neurological
toxins are hitting your brain. Just before you pass out from heat, let me know. Okay. So, hepatic encephalopathy, liver-related consciousness issues, encephalopathy. Okay. Your consciousness is pathological. Okay. What would be, do you think, the major cause of a patient who's had encephalopathy?
It could be alcoholic.
Number one. Yeah.
Or it could be hepatitis.
Yes.
Acute hepatitis.
Yes. So what other sign when a patient who's encephalopathic, what will he have?
Liver flap.
Yeah. Okay. So the liver flap is a sign of a patient whose liver is so sick that the toxins levels in his brain is affecting the proprioceptive input to the brain. So in terms of managing a patient like that, what condition would precipitate an acute encephalopathic patient? So the patient has liver disease, he's in a ward, and then the next morning he's just acutely confused and low level of consciousness. His GCS has dropped.
So they've given him hepatotoxic medication.
Maybe they've given him a drug that he can't metabolize, is now toxic. That's a good cause. Oh, a good answer. What would happen? Okay, let's say if a patient has got liver cirrhosis, what would be happening in his stomach? What would be around happening in his stomach? What is the effects of liver cirrhosis
There's backflow of blood and congestion
in the
in the portal system.
portal circulation? And what will happen next?
There will be increased pressure
In his head?
in his abdomen, in the veins of the abdomen.
What will be the effect of portal hypertension on the veins?
They'll be congested.
Where do they become engorged? Umbilicus?
And flex.
Yeah.
Distal
Distal esophagus? Yes. Yes. So the rectal anal junction. So what is happening in those? Why those three areas?
Because they look at cirrhosis between
That's where there's links between the systemic return and the portal system. So if the portal system is engorged, the pressure turns around. Normally the systemic will flow into the portal areas. Now they turn around. Now they engorge. So if you have engorged veins, varices in the stomach, and they bleed, Cindy, what's going to happen? Are you concentrating?
Yes.
So what's going to happen? If it bleeds into the stomach, what do you think is going to happen to the patient? What will happen if I put blood in your stomach?
There'd be enlarged abdomen.
An enlarged abdomen. How does that work?
Bleeding into the abdomen.
No, I'm bleeding into your stomach. What do you think will happen if there's blood in your stomach?
You'd probably vomit.
Yes. And what will be the color of the vomit? If the blood's been in your stomach and it's mixed with your acid a bit off for a few hours.
Dark red.
Dark red. Have you heard of coffee ground? Have you heard of it? Why does it become coffee ground? Do you know?
Mixed with your
Digested blood looks brownish. So what will be on your finger when you do a rectal if there's an upper GI bleed? Where's my other friend? There she is. Eunice? Answer the question.
Wouldn't it be sort of like Melina?
Never answer with wouldn't it be. Say Melina. And how does Melina look? Have you seen it?
No.
Have you Googled it? Black, tarry, foul-smelling feces. Okay. So now you have a patient who's got chronic liver disease with varices and a bleed in the stomach, an upper GID bleed. That is in essential a protein meal, isn't it? It's like a steak because of all the protein that's in blood. Where's the protein in blood? Marjan?
In the cells.
Yeah, called.
Red blood cells.
Yeah, that's right. What's the protein in the blood in the cells called?
Hemoglobin.
Yes. Did you know about hemoglobin? Good. So you eat a steak essentially. The same will happen if you eat a steak. Okay. Now the blood goes to the GI, and what happens with all that amino acids that comes through the portal system now?
Can't be detoxified or deaminated.
It goes right through the liver in their forms, and they shower the brain. Patient goes encephalopathic. So acute upper GI bleed or infection in his ascites could cause a patient to deteriorate in their level of consciousness. Those are the two big ones for these patients.
How would the infection be
They get delirious. They infection in a patient with chronic liver disease that has the same effect. It can deteriorate their level of consciousness. They get very unwell. So how would you treat it? How would you treat that patient?
Would you give them steroids for the effect of the toxins on the brain itself?
How would the steroids help?
Because is it the inflammatory response on the from the
It's a
brain?
neurotransmitic response.
Okay.
What would you do?
dialysis? Dialysis of the blood.
We do that for kidneys, other type of toxins. Huh? And that's for kidney failure, other toxins. You get rid of the bleeding, so you stop the bleeding, do a gastroscopy and try and sterilize it or stop the bleed, and you clear the gut of the protein. How would you clear the gut? Cindy, what would you give to clear the gut of stuff in it? What would you do? If you want to clear your gut, what would you do?
Laxative.
Do you know a laxative?
Because something softly. By bismuth cell.
It's easy. Senocot, lactulose, clear the gut. Get rid of the protein, get rid of the shower effect. Okay? Right. So another thing that's important in a patient who goes acutely confused with liver disease is you want to do a rectal. For melena, yes, but what else for?
For bleed.
A lower GI bleed probably won't cause it. He will bleed probably if he's at a hemorrhoid, yes? With the rectal.
Oh, sorry, I was thinking urine.
The rectal. Why is the rectal important?
If he has prostate CA, it could metastasize to the CNS.
Yeah. No, that's not the reason I'm thinking of now.
Can you check for varicose veins in the rectum, and that might show you that there's also in the stomach?
Yeah, so you're looking for piles. You won't feel a pile easily because it's quite soft, unless it's thrombosed, it's very sore.
If he had colon cancer, they could do metastases to the liver, which might affect his
Yes.
metabolism.
Yeah, so tumors, but much more common. What would also ooze ammonia into his system, because it's the ammonia, which is this.
The fistulae and the
No. It's the ammonia is a. Yes. What is ammonia? Stikstof. Ach, it's
Nitrogen.
nitrogen. It's nitrogen based, like many of the amino acids. So their nitrogen levels or the ammonia levels with feces and with protein rise tremendously, and that's what also contributes to the encephalopathy. But constipation impacts the feces that's in the colon. It just oozes the stuff into the blood. Normally your liver takes care of it, but so you want to make sure the patient is not constipated. So one of the first things we do for the patient who comes in encephalopathic is do a rectal. It's also, you just clear it also with laxatives, enema. Okay, questions on that? Okay, so the flap will also be a sign of end-stage liver disease. Moving on to friction rub and venous hum, just to say those are very, very rare. Auscultatory findings, so one is of acute hepatitis of the liver, when it's a friction rub against the side of the chest. wall, the ribs. It's similar to a pericardial rub or a pleural rub when you get pericarditis or pleuritis. Okay, so that rubbing. But it's very, these two are much more common. You know, you hear them actually. Venous hum, portal hypertension, I've never heard it. It's a continuous hum because it's venous. It's not, there's no pulsating like a systolic thing. So don't put it really, don't worry about it. Please don't link it first thing in your minds. That's the problem. One wants to teach it, but you don't want to link it immediately. You know, you want to have it really there. Organ enlargement, that's what we spoke about. How do I differentiate between a liver and a kidney and a spleen and a kidney? You know, moves early in inspiration, late in inspiration. Eunice, which organs moves early in inspiration?
The liver and spleen.
Excellent. Which one moves late?
The kidney.
And how would you differentiate between a kidney and a spleen?
Wouldn't the kidney be resonant gases?
Yes, because there's gas overlying. Good. What else?
The kidney on the next to the vertebra.
I can't hear.
The kidney lies next to the vertebra.
Yeah, but that's clinically not going to be helpful. Wait. Put down your hands. What else, if you have a mass there, will make you think this is a kidney or a kidney mass as opposed to a splenic mass?
Oh, you Pilates. I can't Pilates spleen.
You can, well, of course, yeah, you can feel a spleen, but you can block the kidney, yeah. What about your fingers in the costal margin?
Or you do that skin flap for the
Not the skin flap now. Don't bring the skin flap. This is not coming into it now. The skin flap will help you with this, probably, yes. But what will be the, how would you differentiate? Will you get your fingers between a spleen and the costal margin?
Yes, or
No, that's hard. Whereas a kidney in the costal margin, you can get in like now. We feel what can you feel you can get into it? Skin flap? Good. So that's how you differentiate between different things. Direction of blood flow. Do you know how to determine the direction of blood flow in a vein? Cindy, do you know?
no.
Do you know? Who doesn't know? Okay. Africa, what would you do with a vein? Here's a vein. There's valves in the vein. How would I determine what is the direction of blood flow here? What would you do? So close the one end, and then?
See if blood is coming like.
Now, but remember, there's a. I'll show you now. So think about. There's a vein, and it's got blood in it. Now you put your finger on it. What's going to happen to the blood? Nothing. It's going to look exactly the same. But what can you now do to make it look different? It's going to look exactly the same. No. You put your finger next to it, and you swipe it, and then you keep your finger there. Now you've got an area with vein, and flatness in between. Now what you do is you lift the one finger. If it fills quickly, you think, probably flowing in this direction. Let's do it again and lift this one. Because what should happen now? Yeah, theoretically, if the blood's coming from this direction, it can't fill from this way because there will be a valve here. So you have to, you put your finger down, exsanguinate, and lift this one, do it again, and lift the other one, and to see what's the direction of blood flow. You can do it very nicely with the veins on your arms when you have a shower or something. You just clench it and clean it out like this, and lift, and do it again. Try to do this. You need to play with your veins. Now, play is not a negative connotation. You must play with your veins. Cindy, will you play with your veins, please? Or play on other people's veins. Okay? Did you see it? Yeah, you can back of the hand is also quite cool. But you need good veins. Girls, sometimes your veins are not enough. Yeah, can you see it there? Play on other people's veins if you don't have nice veins. So when you do that with the vein on the stomach, you need to determine the direction of blood flow. And then if you have veins all over the stomach, pick a vein that's inferior of the umbilicus. If the blood flows downwards to the toes, then it's kaput medus, right? Away from the umbilicus. If it flows towards the umbilicus or upwards, it's IVC obstruction, and it tries to get to the heart blood. That's if you use veins below the umbilicus. If you use veins above the umbilicus, Now it's hard because if it flows, it could flow anywhere. Because it could be also a vein that goes up, but then it could be caput medusae as well because it's pushing the blood out. And it also goes to the IVC, you don't know. So believe the umbilicus is helpful. Chris?
I just wanted to know what does it help us with? I mean, if we do that.
To determine if it's portal hypertension or IVC obstruction that's causing the big stomach and the dilated veins. Because portal hypertension would be probably liver cirrhosis or clot in the portal vein as opposed to a tumor or a thrombus in the IVC causing this veins in the patients. Will the patient be edematous if there's a thrombus in the IVC?
The IVC?
Yes.
Yes. Yes.
Where will he swell? Where will he start swelling?
Where's the blockage again?
IVC.
IVC. Probably in the abdomen
Why?
and the chest.
How will a thrombus in the IVC swell in the chest?
Well, not so much in the chest, but in the abdomen. I think more in the abdomen, depending where it is.
Explain that to me.
I mean, if the blockage is
Where's the blood from the IVC coming from? Let me
from
help
the
you.
liver. IVC. That's the
Yes.
inferior venous.
Yes.
Yes, from the liver. Yes.
Well, really, in the abdomen.
Well, oh yeah, well, it's coming from the common iliac.
Thank
The
you.
common iliac, yes.
And where does the common iliac come from?
From the legs.
So where would you swell the most distal end of the vein start? Where?
Ankles.
Thank you. Can the patient swell in the abdomen?
Yes.
Eventually they will. But it's exactly like heart failure. It starts at the bottom and moves up. If it's IVC. Portal vein obviously doesn't go to the legs. It goes in the stomach.
So now, is it to say that everyone who has an IVC blockage will
Which is
swell
very
first?
rare.
Yes.
Yes.
Will he always swell first at the feet?
Probably. In the legs. Because those are the veins predominantly going up the IVC. The liver and the stomach and the gut only goes posterior of the liver, so short into the IVC, then they're in the bit in the thorax. So if you have a Bache syndrome, which is a thrombus in the liver veins going from the head back in the posterior side of the liver into the IVC, those three veins, they're a blockage. You'll have a huge liver and portal hypertension. But the IVC will still work. Okay. Cindy, did you follow that one? So that's a complex one, I must say. It's not you need to understand the anatomy very clearly to work it out. Working it out. All right. Female patients, remember the breast tissue. The question is about how do I handle the breast in a cardiothoracic or... The breast tissue actually only comes from an area like that big on the chest normally, although you can have a very big breast. So you need to work above, medial, and lift the breast. Ask the patient to lift their breast. You can do that, and then you do your examination from just where it starts downwards. Okay? So don't try to never work through the breast. Okay? It's painful, it's unprofessional, and you're going to make bad decisions. Work around it. Sometimes you might get a surprise when the breast is lifted. I've seen patients who don't really clean under their breasts. Green mucky stuff. You get it's very but it happens. So when you glove, clean, you continue. That will not happen in the exam. We'll check that first. Okay. All right. Are you happy with that? How to handle a female patient? Right. Venous drainage direction. I think we talked about that. Are we happy? Rebound tenderness. Remember when we do superficial and deep screening palpation in the start of the abdominal exam, peritonitis will come into the game because if the patient is peritonitic all over, you can have guarding, which is a rock hard abdomen because of tonic contraction of the underlying muscles of the abdomen. If it's localized peritonitis, you can have local guarding. Right. Now there are a few tests we do. If you think your patient has peritonitis, in your clinical reasoning you would test for peritonitis. So you want to wiggle the peritoneum, you want to create vibration in it. So you can percuss on the abdomen, that will be tender over the area of peritonitis, either diffuse or local. If you wiggle the umbilicus, which is connected to the peritoneum, it might be painful. If you do a test called rebound tenderness, which is where you press down, when you take a tennis ball and you throw it against the wall and it rebounds, does it rebound slow or quick? Quick. So when you do rebound tenderness, say let's talk about if the patient, here's the patient's abdomen, here's the right iliac fossa, now I'm worried of appendicitis. So I go down deep, and now the patient says, oh, I feel that it's painful now there on the appendix. And then I go like this. That's speed. That's rebound tenderness. You can't do this. I'm just going to leave now. That will not give you rebound tenderness because the peritoneum, you need to scare the peritoneum essentially. Okay.